Good morning. So we'll be discussing about the effect of COVID-19 disease on the myocardium. I have no disclosures pertaining to this talk. So this is the very first report of COVID pneumonia from the Wuhan. And as you can see here, that in the subjects who had adverse outcomes in terms of those who were admitted to the ICU versus those who were not admitted to the ICU, those patients were older in age, they had cardiovascular disease, or they had the risk factors for the cardiovascular disease. And indeed, it was confirmed by the Chinese CDC that the patients who were older, they had higher mortality. As you can see, that with the increasing age, there was an increase in the number of the people who died, or the proportion of the people who died. And similarly, the people who had cardiovascular disease or the risk factors for the cardiovascular disease, they also had a higher mortality as compared to the average mortality seen in various centers in China. Now, this is a bit of a complicated slide here, and I would take you through this, and I will try to simplify it as much as possible. You would see here that in the renin-angiotensin system, we have almost always talked about the angiotensin converting enzyme, which is the pressor arm of the renin-angiotensin system. It leads to vasoconstriction, water and sodium conservation, and adverse remodeling of the myocardium as well as that of vessels. On the other hand, about 2 decades ago, there was a counterpart of the angiotensin converting enzyme, which was discovered, that is called the ACE2, which is the receptor also seen on various organs and various tissues of the body. This counterbalances the ACE arm of the renin-angiotensin system and causes the natriuresis, diuresis, and has a favorable remodeling of the myocardium as well as the antioxidant effects. Now, this converts the angiotensin 2 into angiotensin 1,7, which actually exerts the favorable effects. It has been often thought that the COVID-2, when it enters into various tissues, and we know that it enters into the tissues through the ACE2 receptors, and it destroys those ACE2 receptors. And when we treat these subjects with the ACE inhibitors or angiotensin receptor blockers, it has been tacitly believed that there would be an increase in the ACE2 receptors, and that would be detrimental to these subjects. However, now we know that if the angiotensin receptor blockers are used, the angiotensin 2 remains unused and is converted more towards the angiotensin 1,7. So it is in fact a diversion towards a more favorable side of the renin-angiotensin system. That is why it is suggested that we should not be changing the ACE inhibitors or angiotensin receptor blockers in the patients who develop the COVID disease. Now we know that the ACE2 is present on the various organ and tissues of the body, specifically in the gastrointestinal tracts, various reproductive organs, heart, and the respiratory system. As you can see here, that it is the aerosol or droplet infection. And as it goes through the naropharyngeal mucosa, it is taken up by the ACE2 receptors and is able to enter the cells. It is able to enter the alveolar spaces similarly and is taken over by the ACE2 receptors. And here you can see in one of the very recent reports that there is a diffuse alveolar damage here. As you can see that this is the earlier acute phase where there is the formation of the hyaline membrane. This is the organizing or a phase which may come 4 to 5 days after. So this is an organizing part. And here there is a reparative part. As you can see, the reactive pneumocytes here and the fibrosis which has started to occur. And here you can see some of the inflammation and then the spike protein staining that can be seen in the bronchial epithelium, as well as the spike protein of the COVID virus, which can be seen in the infiltrating macrophages. Now, once it comes here, thereafter, as you can see here, that this is the interaction of the alveolar lining here. As you can see in this area, these are the pneumocytes type 2, pneumocyte type 1, and there is the interaction between the alveolar space epithelium and the endothelium from the capillaries. As you can see here, normally this barrier is the intact barrier, but once the COVID virus is able to enter into the pneumocytes, as you can see here, entering through the ACE2 receptors, it basically eventually would be able to break through the epithelial endothelial barrier. Here you can see it in the histology. And on the right hand side, you can see the comparison that this is the epithelial lining of the alveolar spaces, which has started to disappear because there's a significant damage that is occurring in the alveoli, as this can be seen by the TTF1 staining. And on the other hand, the lining in the capillaries, the endothelial lining, is still pretty much intact and has only been lost at certain places. But as soon as this barrier is lost, there is the entry of these viruses, which comes to the lumen, as well as the macrophages and other cells which have trapped the COVID virus. They would be able to come into the lumen, and these viruses would also be able to hide into the endothelial cells, which is an endothelial monolayer here. Now, in this particular figure, you would be able to see the ultrastructure of various organ systems here, that you can clearly see the viral particles which are present in the tracheal epithelium in the first two subsets here or figures here. And then you will see that they are present in the pneumocytes as well, and then in the enterocytes in the GI system, as well as in the kidney endothelium and kidney proximal convoluted tubule epithelium in this particular case. Now, once it is able to get into the endothelium, endothelium is normally an excellent barrier against the various adverse effects. As you will see that it is anticoagulant or anti-aggregatory for the platelets. It is pro-fibrinolytic, even if there are some thrombotic depositions which occur, it will be able to take care of that with the help of some of the plasminogen activators, which are endogenous activators. It is anti-inflammatory. It also causes the intact barrier function, so that the invading particles or organisms are not able to cross the barrier. Then it is vasodilatory also, as well as it has an antioxidant effect. Once there is the entry of the virus into these cells, or there is an inflammatory insult to the endothelial cells, they lose these effects. They become more procoagulant or pro-aggregatory. There is anti-fibrinolytic systems like the release of the PI1, etc. There is also the pro-inflammatory effect. Barrier function is inhibited. There is a vasoconstriction, and there is a pro-oxidant effect in these cases. This report, which has just appeared in circulation, you would see that as the viral particles enter and then the polypeptides are released, these polypeptides also release the granules by exocytosis from the endothelium. And the two most important things which are released are the P-selectin, which is mounted onto the cell surface of the endothelium, and its expression. Also, there is the von Willebrand factor, which is released, which is bound to the P-selectin, and then the platelets are able to come and aggregate on top of it. The P-selectin also acts as an attractant molecule for the leukocytes also, and gradually the inflammation is able to occur, which, as the barrier function is breached, is able to get into the subendothelial regions. So it looks like that it's a micro and a macrovascular disease which can occur both in the venous as well as on the arterial sites, and the thromboembolic phenomenon would lead to widespread effect. Now, as soon as this all occurs, it looks like that the endothelium is the hub of all the problems here, as has been recently proposed by Dr. Peter Libby and Tom Lucier in their viewpoint in the European Heart Journal, which appeared about a couple of weeks ago. And the most important molecule which is released is the IL-1. These genes are able to induce themselves, so it is kind of auto-stimulatory, and also leads to the upregulation of TNF and the NF kappa B. And this is essentially the inflammation hub here. It also causes the induction of the interleukin 6, which is one of the very important pro-inflammatory molecule, which through liver releases the fibrinogen, the pi1. So fibrinogen, which is pro-coagulation, pi1, which is anti-fibrinolytic, or which impairs the fibrinolysis here, as well as there is a release of CRP, which we are able to measure as a biomarker of inflammation in the patients with COVID infections. So essentially, this pro-inflammatory, pro-coagulant pathway that we see becomes essentially the key feature in the COVID infection. And it has been demonstrated that if you look at the patients who have a favorable outcome, as shown by the blue line compared to the red lines here in these graphs, that after the 4 days of infection in the subjects who are hospitalized, you will see that these pro-inflammatory, pro-coagulant pathways, they are significantly active in the subjects who have adverse outcomes or who are non-survivors as compared to the survivors, whether it is the D dimers, interleukin 6, or the troponemia in these cases. Now, in these vessels, it has been shown, at least for the larger vessels, although these data are not available for the coronaries as yet. In this particular case, as you can see in this CT, that the thrombus is occurring in the aorta as well as in the splenic artery here. So if you look at the iliac and the splenic artery in these cases, that there was a significant intraluminal thrombosis here, as well as the inflammation of both within the wall as well as in the adventitial areas and perivascularly, that there was a significant inflammation. Not only that, there was evidence of fibrinoid degeneration, which was possibly associated with significant neutrophilic infiltration, where it is interacting with the mast cells, and there's a degranulation of the mast cell occurring in this case. There has been an evidence that there is a significant amount of neutrophil extracellular traps which are set up, and that contribute to the damage in these cases. And in the bottom panel, you can see the complements as well as the immunoglobulins that are depositing in there, suggesting that this is a type 3 hypersensitivity in the vessel. So whenever you see the complement deposition in the vessels, it probably always represents the hypersensitivity in these cases. Now, this is procoagulant activity which is happening, and you can see the thrombus in the vasculature, as is seen very commonly and very frequently in the autopsies which have been presented so far. It may occur in the deep veins. Maybe a large proportion of the subjects may have the deep venous thrombosis, even up to about 70 to 80% of them. Up to 30% of them have the venous thromboembolic phenomenon, and a smaller number of the cases will have the strokes as well as the limbs and gangrenous toes in these cases. And most importantly, the thromboembolic phenomenon may occur in the upper extremities as well, unlike what we normally see. So when there is the COVID involvement, you can summarize it as was shown in one of these review articles. And these are the hypothetical mechanisms here, that SARS-CoV-2 virus anchors on the transmembrane ACE2 receptors to enter the host cells, including type 2 pneumocytes, macrophages, endothelial cells, pericytes. And it infects the respiratory tract, and particularly the type 2 pneumocyte results in local respiratory damage, followed by progressive systemic inflammation, often leading to cytokine storm, with increased levels of IL-6, 7, 22, and CXCL10. Now, as you can see here, that once it is blood-borne and once the various endothelial cells of the body have already been invaded by the virus, it should be easy for the virus to get into the myocytes in the heart, and it should be able to create a significantly large amount of myocarditis. And had it been so, then most of the people you would have seen should have been dying of heart failure and myocarditis. Now, as you can see here, that in the myocardium, there's a large amount of expression of various pro-inflammatory molecules, specifically when the viral load is higher as compared to those where the viral load is less. However, when we look at the histology, we see that there are some inflammatory cells here and there, but in the myocytes, you would not see much of a damage occurring in these cases, regardless whether there was a high viral load or there was a less or a mild viral load. The viral particles are seen in the myocardium. As you can see here, there is an immunohistochemical staining of the viral particles, but viral particles in these cells are essentially in the macrophages or in the interstitial cells. And this was very elegantly shown by a report that comes from Italy from Dr. Tavazzi's group with Dr. Luisa Arbustini, the pathologist here, who also demonstrated that there was some plump macrophages which were seen in the myocardium within the interstitium here, but and this is the electron microscopy of the macrophage, and these carried the viral particles, but viral particles were not seen in the myocardium. And here you can clearly see the presence of the viral particles here. You can see them here with the corona of the S proteins or the spike proteins here. You can see them all either in the macrophages or in the interstitial cells, but they were not seen in the myocytes. Now here there was a decent report which just came about a week ago, again from Italy, but in collaboration with Mayo Clinic, Mass General Hospital, and University of Amsterdam Medical Center. Again, they saw that there was at least in approximately 80% or 80+% of the cases, there was macrophage infiltration in the myocardium. Lymphocytic myocarditis was only seen, which was either because of the cytotoxic T cells or because of the helper T cells, but that was only seen in 3 of the cases, or 1/7 of the cases only. And in approximately 1/6 of the cases, you can see that or of a fifth of the cases, there was the presence of pericarditis or epicarditis in these cases. And there was also the small vascular involvement. You can see the intraluminal thrombi in these cases, as well as there is a significant amount of inflammation that you can see in these vasculature. At the same time, there was another report which was published in Circulation, where they demonstrated that in 22 autopsy hearts, in 9, there was a significant enlargement of the right ventricular cavity here. And as you can see here, that the right ventricular cavity, its volume is bigger than the left ventricular cavity volume, more than 1.1:1 that was seen. And the inflammation was predominantly in the right ventricular wall, was predominantly the macrophage infiltration. Not only that, in these right ventricles, by the same Italian report which you had seen earlier from Dr. Basso's group, you would see that the complement deposition occur in the myocytes in the right ventricle. And whenever that occurs, unlike in the vessels where it was hypersensitivity, it is believed that this is because of the ischemic damage to the myocytes. And this is something which has a significant clinical implication, which we recently published in our echocardiographic study, which I will come to a little later. Now here you would see that all this is going on. You can see a significant cytokine-based damage which is occurring in these cases, but the viral particles are not seen in the myocytes as much. There have been some reports where there have been isolated myocytes have been shown with the viral particles, but it is predominantly not seen there. So how can that be explained? And here you would see that this is the coronavirus. How does it get into the cell or tissues? It is by the spike proteins of the coronavirus that bind to the ACE2 receptor or ACE2 receptor expression on the cell membranes. But then it requires a co-stimulatory molecule, which is like tempress 2, and it cleaves that off, letting the virus be endocytosed into the cell. However, if either the ACE2 is not present or if the tempress2 is not present, so either this receptor molecule or the co-stimulatory molecule, either one of them not being present, the cell will not be able to be engulfed. So in heart, where we see a large amount of the ACE2 expression, we don't see the presence of tempress2 or the co-stimulatory molecule, and hence the viruses are not able to get into the myocytes so easily. And this is the RNA master blots. You can see that in the hearts, there is not much of expression. It is in the lane 3, and the first one is the RNA blot for the tempress2 in the heart, as compared to the lung and trachea, which you can see in the row 6, that there is a significant expression of the tempress2. The maximum amount is generally seen in the prostate and in the stomach, etc. So now coming to the clinical implications of all this, the first important thing is the thromboembolic complications. So among hospitalized patients, the new thromboembolism has emerged as an important disease manifestation. The autopsy studies have demonstrated a high incidence of macro and micro thrombi, as I alluded to earlier. The observational analyses have suggested potential benefit for in-hospital use of anticoagulation, yet practice patterns vary significantly due to the lack of rigorous evidence for optimal regimens. In our preliminary analysis of 2,700 patients admitted to Mount Sinai Health System, we found an association between in-hospital therapeutic anticoagulation and improved survival compared to patients on no or prophylactic doses of the anticoagulation. A follow-up study which just got published with 4,500 patients, where 1,000 patients were on therapeutic anticoagulation and 2,000 people were on prophylactic anticoagulation, were compared with 1,500 patients on no anticoagulants. And it was found that the hazard ratio was approximately 50% lower in the subjects who were either on uh, full dose or on the prophylactic dose of anticoagulation, as compared to the subjects who were not on any prophylactic or any full anticoagulation dose. And the total mortality in hospital was 25%, with twofold higher likelihood of having the mortality as compared to those who have received any kind of anticoagulation in these cases. So, not only that, when you would see the myocardial injury happening, and most likely it is either the microvascular thrombi or it is the cytokine stress in these cases, we reported in 3,000 subjects from the Mount Sinai Health System, where there were a large number of African Americans and large proportion of the Hispanic population. About a quarter of these subjects also had the presence of cardiovascular disease or atrial fibrillation, heart failure, or coronary artery disease. 25% had the risk factors for coronary artery disease or cardiovascular disease, and 25% of the patients were receiving the ACEs or ARBs, and a third of the subjects were on statins. We found that in third of the subjects, there was the troponin leak that occurred, suggesting troponemia or evidence of myocyte damage. But as you can see here, that most of these subjects had only a mild troponemia or mild leak, and the less of the people had the severe leak of troponin. And here you can see that those who had coronary artery disease, cardiovascular disease, or risk factors, which are shown here in red color and red dots here, as compared to those who did not have cardiovascular disease or the risk factors, the levels of troponin were always higher in those who had the evidence of cardiovascular disease. And in fact, higher the troponin leak, as you can see here from left to right, the troponin leak is increasing. And if green is the total number of the subjects, and if blue are the patients who have recovered, and red are the patients who have died, you can see that as the level of the troponin leak is increasing, the number of the subjects who are recovering is decreasing, and number of the subjects who are dying have increased significantly. Now, here, this is a subject who is presenting with ST elevation myocardial infarction type of a picture. But as you can see here, there is a right ventricular enlargement in this particular case. In the bottom panel, you will see the patient who came with a normal size of right ventricle. But on the third day, the patient had a significant enlargement of the right ventricle. And as I said earlier, that this is one of the sinister observations, that the right ventricular enlargement and right ventricular dysfunction correlates even regardless of the pulmonary arterial hypertension status, possibly suggesting that this is a cytokine effect on a thinner myocardium of the right ventricle. However, simultaneously, there have some reports which have come from Italy and some of the other parts of the world where they have shown a Kawasaki disease type of a picture. It is not a classic Kawasaki, but something like a Kawasaki pictures, predominantly in the younger subjects, maybe older than what we see Kawasaki in. And these are the subjects, most of them have already not antigen positive anymore, but most of them are antibody positive. And in one of such cases, there was a presence of the viral particles, which was seen in the myocytes also, not only in the interstitial cells as well as in the macrophages, but also in the myocytes. And then you would see that there was some evidence of myocarditis occurring in such cases. And it is possible that this is occurring probably due to the macrophage activation syndrome, or because of the very high cytokines in these cases, even after the antigen has disappeared. Now, it has also been shown, and this has created a stir in the athletic industry of at least United States and some of the European countries, that it has been found that the athletes or the people who have suffered from the COVID in past may, even after they have recovered from the COVID disease completely, may demonstrate the evidence of the edema and increase in the extracellular fraction in their myocardium. As you can see here in the mid myocardium, you can clearly see that the T1 and the T2 are increased. And in these subjects where the T1 and T2 are increased, which suggests the presence of edema or the presence of the increase in the extracellular fraction, and also a possibility that you may have the LGE enhancement, suggesting thereby that the earlier fibrosis has started to occur. It has suggested that these people may not be allowed to immediately get into the competitive sports, and the caution has been exercised in such cases. So at the end, I would like to say that if we are able to understand the pathogenesis and the pathophysiology of the disease, we would be able to treat our patients better. In this particular paper, or a viewpoint, which is coming out in the American Journal of Medicine soon, we have proposed that the subjects who have the asymptomatic disease, that is, they are positive for their swabs, but they are still asymptomatic, or if these subjects have they are mildly symptomatic and they are not admitted in the hospital, the only drug that would be effective in such cases would be when we have an availability of an antiviral agent. Currently, the only agent that we are able to use is remdesivir, and then once the patient is symptomatic and he gets into the hospital and may not yet be on the ventilatory support, in such cases, probably the antivirals may still work. The steroids and the immunomodulatory agent, quite like the IL-6 inhibitors, may be given in this situation. The plasma therapy could be of help, but as you would have seen that today, there was a report in the morning in Science where it was demonstrated that we have to be careful about the plasma therapy also, because Some of the people who have the worst course, these people develop the autoantibodies to type 1 interferons. That is most likely interferon alpha and interferon omega. In these cases, the plasma therapy we should be careful about the plasma therapy, that it may not give the auto antibodies and it may not suppress the interferon effects or the favorable effects in the patients. However, once the patient is on the ventilatory support for a long period of time, probably all these agents that we have talked of may not really be helpful. And here it should only be the supportive therapy which would be able to help these subjects. Ironically, most of the studies that have been done, be it randomized or observational studies, they have all been done in this phase where you would not expect much of an impact of the drugs, which may be more effective in the early phases of the disease. Thank you very much.